Okay, so this is all about the mechanisms of target organ toxicity. So we will discuss the mechanisms of cardiovascular drugs, then respiratory. We also have analgesics, anti-infectives, and then anti-inflammatory agent. But we will not focus on their mechanism of action as therapeutic agents, but more on their mechanisms of toxicity. So starting off with the different cardiovascular drugs, so we will discuss or we will focus on these four major cardiovascular drug classifications, starting off with the cardiac glycoside. So remember class or recall no that cardiac glycosides are usually indicated for conditions like heart failure. So heart failure wherein there is inability of the ventricle, either the left or the right ventricle to deliver blood to the tissues under a normal activity or rest. So one type of heart failure is called congestive heart failure where there is congestive because there is accumulation of fluid or excessive fluid, again, due to the inability of the heart to pump or deliver blood, then resulting now to edematous states or edema due to the pump failure. So there are two types of heart failure. The left side is because left ventricle is affected and then characterized by dyspnea and wheezing, so affecting the lungs. Then right-sided failure affecting the right ventricle, characterized by peripheral edema and then visceral edema. So just to review the flow of blood no once the oxygenated blood reaches the heart. So remember class that deoxygenated blood, ibig sabihin yung blood na hindi pa nawala pang oxygen or hindi pa dumadaan sa lungs, enters the superior vena cava and then it goes now to the right atrium, then passing to the tricuspid valve. So remember valves, di ba? Valves prevent the backflow of blood. Then going to the right ventricle and then the blood will enter now the pulmonary artery where the blood will be delivered to the lungs and then the blood now will be oxygenated here. Kanina pumasok deoxygenated. Then it passes now through the lungs where the blood becomes oxygenated. Now, it re-enters the heart through the pulmonary vein, going to the left atrium, going to the left ventricle, and then now going to the aorta where the blood, oxygenated blood is delivered to our tissues. So anong nangyayari class kapag merong left-sided heart failure? So what happens is the left ventricle fails to pump enough blood. So ang nangyayari instead of the left ventricle pumping no the blood to the aorta and then aorta to delivering it to our tissues, the left ventricle fails to pump blood. So the blood now or fluid accumulates on this part. No, instead of being delivered, it accumulates particularly sa pulmonary vein. Eh alam naman natin yung nakadugtong sa pulmonary vein would be the lungs. Kaya anong mapapansin niyo sa manifestation of left-sided failure, dyspnea, difficulty in breathing, and then there is also wheezing. It's instead of the blood being delivered no by the left ventricle to the aorta, it fails to pump the blood and now accumulates within the pulmonary vein, affecting the lungs. So that is for left-sided failure. In fact, this is the most common type of, a more common type of heart failure is the left-sided failure. Next, how about the right-sided failure? Right-sided because the right ventricle is affected. So right-sided because the right ventricle is affected. Supposedly, right ventricle will push or will pump the blood going to the pulmonary artery, going to the lungs. However, ang nangyayari, the right ventricle fails no to pump the blood going to the lungs. So anong nangyayari? Instead of the blood going to the lungs, it backflows no. Babalik going now to the peripheral tissue. Kaya ano ang manifestation ng right-sided. There is peripheral edema, there is visceral edema. Kaya yun yung nakikita natin na usually nangyayari, parang nagkakaroon ng swelling ng legs, no, edematous states, no, ng mga extremities, peripheral and visceral edema because of instead of the blood being delivered to the lungs, pumped by the right ventricle fails to pump the blood. Therefore, it goes back to the periphery, causing now accumulation of fluids such as peripheral or visceral edema. Now, our drug for heart failure, to be specific for CHF, is the digoxin or lanoxin, which is still available now. No? The source, what is our source of digoxin is the Digitalis lanata. And what is the common name of this plant? Class, can you still remember in your pharmacognosy? What is the common name of Digitalis? Letter F. This is also known as what? Letter F. What is the common name of Digitalis? Foxglove. Very good. Available at which concentration? 250 micrograms. So, ganun ka-potent si digoxin. And yung brand niya from GlaxoSmithKline is Lanoxin. Maliit lang tong tablet na to for the treatment of CHF. Now, going to its mechanism of action, recall lang naman or review, but we will focus on the toxicity, is it inhibits the sodium-potassium ATPase, which is a channel found within the cardiac cells or the heart cells. So the mechanism is it inhibits the sodium-potassium ATPase. So ano nga ulit ang function nitong channel na to? Sodium-potassium ATPase allows the entry of potassium ion and then allows the release of the sodium ion. So once the sodium potassium ATPase is inhibited by Digitalis, ang nangyayari kasi the sodium ion is prevented from being released from the heart cells or from the cardiac cells. And then now allowing indirectly the increase of the intracellular calcium via the sodium-calcium exchanger. So once the release of the sodium ion is prevented, it will also affect the release of the intracellular calcium via the sodium-calcium exchanger. So an increase in the sodium ion will also increase the intracellular calcium. And now, the effect of calcium is positive inotropy. Ibig sabihin, it will increase the force of cardiac contraction. Kasi sa heart failure, di ba, the heart has inability to pump the blood. But by increasing the intracellular calcium, the effect is positive. It increases the inotropy or the force of cardiac contraction. Now, for the toxicity of digoxin, it can affect yung electrical impulses sa heart natin causing arrhythmia. So it has electrical effects. Gastrointestinal disturbances, overdose of digoxin can cause vomiting. So that's one effect of digoxin. As it causes GI disturbances, it specifically causes vomiting. Hyperkalemia is also another manifestation of digoxin toxicity. Overdose. Hypokalemia when given with other agents that also causes hypokalemia. And then visual disturbances, mga red to green visual disturbances kasi mataas yung level ng sodium potassium ATPase sa retina ng mata. So the number of sodium potassium ATPase, which is the binding site of digoxin, is high. Our retina has no sodium potassium ATPase. That's why toxicity of digoxin can cause visual disturbances. So for the management, we have an antidote for digoxin toxicity called the Digibind, Digifab. These are actually antibodies. So take note antibodies against digoxin. Again, Digibind and Digifab, kaya AB yan antibodies against digoxin. So they are administered intravenously for digoxin toxicity. Antibodies for digoxin. So arrhythmia, vomiting, hyperkalemia, hypokalemia when given with agents like diuretics. Yan, so they can induce hypokalemia with diuretics. Visual disturbances, mga red to green visual disturbances. Next would be anti-arrhythmic agents. So before I discuss the toxicities of anti-arrhythmic agents, let us review the conducting system of the heart. Because remember, no, electrical impulses are the one responsible for heart contraction. Ano nga ulit yung frequency ng heart rate natin, class? Review tayo. What is the frequency ng heart rate natin? What's the normal per minute? How many? How many beats per minute? Because the one responsible, no, the one responsible for conduction or kaya yung heart natin nagko-contract because of the electrical impulses. And yung frequency niya is 60 to 100 beats per minute. So again, these electrical impulses or yung tinatawag nating action potential is the one responsible for heart contraction. That's the reason why our heart beats at a rate of 60 to 100 beats per minute because of the conducting system of the heart or these electrical impulses na sinasabi ko or the action potential. So these electrical impulses, which is the one responsible for the cardiac contraction, originates from the SA node. And then it will spread, no, to the left atrium and to the right atrium. And then it will go to the AV node, passing through the AV bundle. So makikita nyo dito, class, the AV bundle is divided into two branches, the right and the left bundle branches. And then going now to the Purkinje fibers found at the tip of the heart. So the electrical impulses originate, no, from the SA node, then it will spread to the right and the left atrium, going to the AV node, to the AV bundle, to the right and left bundle branches to the Purkinje fibers. So these electrical impulses originating from the SA node is the one responsible for cardiac contraction. So any disturbance, no, in the normal flow of this electrical impulse, let's say, affecting the initiation, yung duration, and propagation of this electrical impulse can result to a condition known as arrhythmia. So if there is a disturbance, no, from this electrical impulse responsible for heart contraction, it leads to a condition known as arrhythmia. And this is where we administer, or this is the indication of the anti-arrhythmic agents. So, arrhythmia or anti-arrhythmic agents, they address, no, the problems with the rate or the rhythm of the heart. Kasi going back nga, di ba, ang normal lang talaga is 60 to 100 beats per minute. But if there would be any problem, let's say, with the rate or rhythm of this heartbeat, anti-arrhythmic agents are given. So we have the following, no, we have the following conditions. Example, we have the irregular heartbeat. We call the condition as dysrhythmia. So irregular heartbeat causes dysrhythmia. And then how about fast? How about fast? What is our medical term for a fast heart rate? Ayan, meron yan dito. Yes, tachycardia. And pag slow naman, class, what is our term for that kapag slow? We have bradycardia. So we have dysrhythmia for irregular, fast is tachy, and slow is bradycardia. And then the good thing about these electrical impulses, they can actually be measured using electrocardiogram or ECG. So I'm not sure kung naka-experience na kayo before ng ECG, but these electrical impulses generated from the or originating from the SA node can actually be measured, no, using the ECG. This action potential can be measured using electrocardiogram or ECG, and then they represent the following. So the P waves, the QRS complex, and then the T wave. So the P wave represents atrial depolarization. Pag sinabi nating depolarization, atrial contraction. Again, the P wave represents atrial depolarization or atrial contraction. contraction, atrial contraction. Then the QRS complex represents ventricular depolarization. Ano nga pag depolarization? Ventricular depolarization or what? Ventricular depolarization or also known as ventricular, letter C, contraction. How about atrial repolarization? Atrial repolarization is atrial relaxation. Very good, relaxation. So ventricular depolarization or ventricular contraction, and then atrial repolarization or atrial relaxation. Then lastly, the T wave represents ventricular repolarization or also known as ventricular relaxation. So any problem, no, with the heart rhythm or rate of the heartbeat may cause the following conditions, such as atrial fibrillation, ventricular fibrillation, and torsades de pointes, or the TDP, which is a life-threatening condition. So you have the AFib, the VFib, tsaka yung TDP, which is a life-threatening condition. Now, what do we give during arrhythmia? So we have the following anti-arrhythmic agents, no? We have different classes, the sodium channel blockers, the beta blockers, the potassium channel blockers, and then the calcium channel blockers. And then they differ. Before that, class 1 can be further divided into 3 groups, no? The 1A, 1B, and 1C, depending on their effect on the actual action potential duration. And then for the different classes of antiarrhythmics, they differ depending on their target. So, kagaya nga ng class 1, they are the sodium channel blockers. Class 2 are the beta. Class 3 are the potassium channel blockers. And then class 4 naman ang calcium channel blockers. So, let us discuss class 1A. So, class 1A, we have the following. I'm not sure no if na-share na sa inyo tong mnemonics na to. Pero for class 1A, we have double quarter pound. Type natin. Double. Na-share na ba to class? Baka na-share na. Double quarter pound. Bakit siya double quarter pound? Kasi D is for disopyramide, quinidine, tsaka P is for procainamide. So, double quarter pound. So, disopyramide, the effect of this drug is parasympatholytic. So, it has a atropine-like activity. So, disopyramide has an atropine-like activity. So, it's parasympatholytic, anticholinergic, no? Atropine-like activity. Quinidine naman elicits or exhibits synchronism kasi derivative siya ng quinine natin from cinchona bark. So, alam natin pag overdose, it causes what? Headache and then ringing of the ears or tinnitus. So, that's for quinidine kasi derivative siya ng quinine natin from the cinchona. Kaya synchronism, di ba? Headache, tapos ringing of the ears, dizziness, yan, tinnitus. And then procainamide has SLE-like symptoms. So, double quarter pound. How about class 1B? I'm not sure if na-share na rin sa inyo tong mnemonics, pero we have too much love, pregnant. Yan. So, para lang maalala nyo din. Tokainide, mexiletine, lidocaine, tsaka P is for phenytoin. Tokainide, mexiletine, lidocaine, tapos P is phenytoin or phenytoin. So, tokainide and phenytoin or phenytoin causes hirsutism and SJS, Stevens-Johnson disease. Phenytoin, aside from being anti-arrhythmic, saan pa siya ginagamit, class? Review tayo. Saan natin ginagamit pa ang phenytoin? Wala, pharmacology 1 yata to, PCOL 1. Naku, nakalimutan na. Diba this is an anticonvulsant? Si Dilantin. Ayan, very good. Si Dilantin, diba? Anticonvulsant. Then, mexiletine, which somewhat resembles lidocaine. causing blood dyscrasia, and then lidocaine, although considered to no as the least cardiotoxic among these antiarrhythmic agents, ang lidocaine, but it may cause methemoglobinemia. Although in terms of its cardiac effects, ang lidocaine again is the least cardiotoxic among this anti-arrhythmic agent. So tokainide, phenytoin, too much love, mexiletine, which somewhat resembles the effect of lidocaine. And then love, lidocaine, causing methemoglobinemia. And then P is for pregnant, pregnant phenytoin. Then class 1C naman, we have more rice, please. Ayan. More fries, please, kasi moricizine, then flecainide, letter P is propafenone, and E is for enkainide. More fries, please. Moricizine, flecainide, propafenone, tsaka enkainide. Moricizine and flecainide should never be given with patients who just suffered from myocardial infarction. So, contraindicated siya sa mga taong naka-experience lang recently ng heart attack or MI. Kasi they can actually increase the mortality of those patients recovering from an episode of myocardial infarction. So, moricizine and flecainide can increase the mortality of those patients who are still recovering from MI or myocardial infarction. Then propafenone naman, enkainide, meron din silang effect on the heart. So they are contraindicated to those patients with cardiac dysfunction. So with existing heart condition, or again, for those patients with cardiac dysfunction. So propafenone and enkainide are contraindicated to them. So generally, hindi na rin masyadong ginagamit yung mga class 1 antiarrhythmics because of their toxicity. So in fact, aside from bradycardia, they are also considered as pro-arrhythmics kasi at some point, they also modify or they also affect yung normal rhythm of the heart. Kaya all antiarrhythmics are considered to be pro-arrhythmics at some point. Kasi gagalawin din nila yung normal, or rather gagalawin din nila yung electrical impulse or yung pinaka-rhythm ng heart because that is their effect, that is their action. Meron silang electrical effects on the heart. That's why they are also considered to be pro-arrhythmic. So we have the sodium channel blockers. Next would be the class 2 antiarrhythmics. So we have beta-1 selective, tsaka yung non-selective beta blockers. Then, for the management, we have glucagon. So this is what you have to remember, class. Take note, although esmolol, esbutalol, atenolol, metoprolol are selective to beta-1, but high dose or administration of high doses of the said drugs, they can actually lose their selectivity. So take note, beta-1 selective agents, although they are beta-1 selective, their effect is only limited to the beta-1 receptor. But if you administer high doses of these drugs during overdose, they can even lose their selectivity. So that's the problem with beta-1 selective. They can lose their selectivity. And then some beta blockers, they possess or they elicit intrinsic sympathomimetic activity. So one is esbutalol, we have penbutolol, tsaka pindolol. So type ko na lang, those beta blockers with ISA, penbutolol, esbutalol, and pindolol are those beta blockers with intrinsic sympathomimetic activity. Penbutolol, esbutalol, and then pindolol. And then what is the feature of esmolol class? Ano ang meron ulit kay esmolol? Is it the longest or the shortest acting beta blocker? Okay, very good. No, it's the shortest beta blocker. Beta 1 selective blocker that it has a half-life of 10 minutes. So it's the shortest acting beta blocker with a half-life of 10 minutes. And then now we have non-selective, the propranolol, tsaka sotalol. So both for beta 1 and beta 2. What would be the effect of propranolol in beta 2 receptor? So natatandaan pa. Or saan contraindicated ang mga non-selective beta blockers? They are contraindicated to which type of patient? Since they target both beta 1 and beta 2, they are contraindicated to which type of patient? Okay, very good. Asthmatic, di ba? Kasi nga, the effect of beta blockers, non-selective beta blockers to beta 2 receptor is bronchoconstriction. So that's why they are contraindicated to patients that are asthmatic. Now, class, I think may question yata dun sa, sa questions to answer nyo sa data sheet or dun sa activity nyo na which is the most toxic yata, the most cardiotoxic cardiovascular agent. May ganun ata ang tanong, no? So the answer is propranolol because of its non-selectivity, because it's non-selective too. Because it's non-selective and it targets both beta 1 and beta 2. So the most cardiotoxic would be propranolol. Kasi nga it targets both beta 1 tsaka beta 2. So take note. Next would be class 3 antiarrhythmics. So we have the following. Okay. So class 3 antiarrhythmics would include yung ating potassium channel blocker, which is we have amiodarone with broad spectrum antiarrhythmic activity. So we have the following toxicities no associated with amiodarone. Pulmonary fibrosis affecting the lungs. This is one of the classic manifestation of amiodarone toxicity. And then thyroid effect. Kasi ang amiodarone class, iodinated to. IOD. So yung IOD dito because it is a drug that is iodinated. So it has the following thyroid effect, possible effect on the thyroid function, either causing hypothyroidism, causing the Wolff-Chaikoff effect. Because of the sudden increase in the iodine, kasi nga amiodarone is a drug that is iodinated. So a sudden increase in the iodine when the drug is taken can result to hypothyroidism such as the Wolff-Chaikoff effect. Now, dun sa mga patients na meron silang normal thyroid function, they can escape the Wolff-Chaikoff effect. But for those patients na merong existing thyroid problem, the Wolff-Chaikoff effect is usually observed or is usually seen. So hypothyroidism because of the sudden increase in the iodine concentration when amiodarone drug is taken may result to Wolff-Chaikoff effect. But it may last only up to 14 days. And kagaya nga ng sabi ko, kung yung pasyente naman may normal thyroid function, the patient can usually escape the Wolff-Chaikoff effect. Then another possible effect would be hyperthyroidism causing thyrotoxicosis and then hepatotoxicity. So we have the following management procedures for the toxicity associated with amiodarone. So isa na doon is to stop really the medication kung nakikita na natin yung mga ganitong toxicity. Corticosteroids, example for pulmonary fibrosis. Kasi this is the most serious, considered to be the most serious adverse effect of amiodarone. So wherein the lungs are damaged, so we can give corticosteroids. And then hyperthyroidism, we have the removal of the thyroid gland itself. Kapag talaga severely affected, thyroidectomy can be performed. And then other class 3 antiarrhythmics, although sotalol is a beta blocker, but as an antiarrhythmic agent, it is classified as class 3 together with bretiline. And then lastly, we have class 4 antiarrhythmics. We have the phenylalkylamine. So the action is to depress the sinus and the AV node. We have the verapamil. Then benzodiazepine, we have diltiazem. And then the dihydropyridines, yung mga dipine like amlodipine and then felodipine. So constipation, this is usually seen in patients who are taking verapamil. So please take note that constipation is usually seen for patients taking verapamil. Diltiazem, usually rashes. Rashes naman ang common, no, for patients taking diltiazem. So our management would be glucagon for these patients. So before I proceed with angina pectoris, let's take a short 5-minute break. So tamang-tama, we have 5 minutes left no before the meeting ends. So mag-break muna tayo for 5 minutes.